Low back pain is the #1 disability amongst industrialized nations. On average, it costs about $90 billion annually. $90 billion. And what's wild is the prevalence of chronic low back pain is increasing. So let's dive into the research on low back pain. My name is Shines Farr. I'm an orthopedic clinical specialist for physical therapy. I am also a professional stuntman, competitive martial artist, and professional breakdancer. I've treated many cases of low back pain and experienced low back pain myself, so let's dive into the literature. The intention of this video is to educate you on what the research says about low back pain. However, this should and does not substitute a medical exam. If you're really serious about recovering from an injury like this or experiencing something like that, it's best you go see a clinician so that they can account all the unique factors about your case. Most of this video will be referencing the American Physical Therapy's clinical practice guidelines on low back pain, and I hope that helps you understand what as clinicians we're trying to offer you. Now, before we get into the treatment, I think it's really important we talk about what is going on, what's causing it, and how that influences the rehab protocol. Now, this may come as a surprise to you, but the entire medical community does not have an excellent understanding of the exact tissue sources that can cause back pain. There's a lot of possible tissue sources, whether it's disc, muscle, nerve, ligament, facet, and even as a matter of fact, even the American College of Physicians advises against getting routine MRIs on low back pain because it may not lead to the correct diagnosis and oftentimes can even cause more fear. I know this comes as a shock to many of you because we often hold MRIs as like the supreme source of knowledge. And instead they say we should only use MRIs in the presence of red flags, meaning something that we think is a little bit more dangerous, or progressive worsening neurological symptoms. What that means is, in your evaluation, your physician or physical therapist is going to ask you some questions. And if they determine that maybe there's something else going on, that's where they might refer an MRI. But don't be surprised if they don't. It doesn't mean that they're being lackluster. Oftentimes, they're actually trying to do it for your benefit. Part of the reason is that there are some studies that show that even asymptomatic, meaning people without symptoms, healthy 30-year-olds will show disc herniations or bulges on an MRI, but they don't have back pain. So imaging does not correlate with pain. And the problem is sometimes if we go see something on an image, now we're stuck with that for the rest of our life, when that might not actually be the cause of your back pain to begin with. So in the absence of red flags, instead of just going straight to an MRI, I want to do a thorough exam to see what are the impairments or deficits my patient is presenting with so that I can create a profile for them to show how we can improve their body. One of the really interesting things that the American Physical Therapy has done is created these classification criteria. And there's 4 for low back pain. It's low back pain with related lower leg pain, low back pain with radiating pain, low back pain with mobility deficits, low back pain with muscle power and coordination deficits. I know it's a mouthful and I'm going to dive into what that looks like. So let's talk about the first 2. I know it sounds really similar. Related lower leg pain and radiating leg pain. And although they sound similar, they're actually quite different. Now, related lower leg pain is what we think about when we think about somebody that has like a disky presentation. Often it's people that present with low back pain, but they also kind of get this like vague pain that's in their leg too. What's different about this with radiating leg pain is more of a nervy presentation. Those are people that have this kind of like lateral posterior leg pain that might accompany with like burning, numbness, tingling, and even weakness. Related lower leg pain looks a little different. It doesn't follow this almost like clean stripe, and instead it's a little bit more vague and all around the leg. What's interesting about related lower leg pain is it can sometimes respond really well to what we call directional preference exercises, which essentially means oftentimes when people bend forward or their back is flexed and they're in this profile, the symptoms will kind of travel further down their leg. And instead, when they extend, the symptoms, although might still be there, are going away from their leg and closer to the spine. This is a good thing. Sometimes people think, oh, just because they still have pain, it's not working. That's not the case. If the symptoms are getting closer to the spine, that's a good sign. Even if the pain is still the same intensity or even more, if it's getting closer towards your back and away from your leg, that can be a good sign. This is really nuanced, so I really, again, advise a clinician to help you diagnose this. I just want to provide you with this insight. Radiating leg pain is more of a nervy presentation. The thing about this is we need to make sure if that nerve is being irritated, it's still safe because we're worried about something called Codd-Aquinas syndrome. That is an emergency and needs to be treated as so because there's some time sensitivity to that. So as a clinician, if somebody presents this with me and in my neuro screen, I see something a little bit more concerning, I'm stopping the treatment right there and we're going to the hospital. If in the neuro screen I see a little bit of numbness, maybe a tiny bit of weakness, and even the reflexes are off, that's okay. It's something to know, but we want to treat it and maybe even be ready to get some eyes on it. Not only do they present kind of subtly different, related lower leg pain and radiating lower leg pain, they're also often caused by different things. Related lower leg pain, that vague feeling on your leg, is often caused by sitting, lots of flexion, people that have a flattened spine, really stiff hamstrings. The proposed hypothesis is it puts a little pressure on the discs, and the discs have this referral pattern down the leg. Radiating leg pain is thought to be a little bit of a nerve entrapment. And those actually tend to be people that are a little bit more extension. Their back might be lordotic. There's other reasons too. Could be piriformis or an entrapment somewhere else. The reason it's important to distinguish the two is they almost have opposite treatment strategies. With related lower leg pain, depending on what we find, oftentimes we're talking about a walking program because walking helps really hydrate those discs. We're talking about extension exercises. However, that might actually irritate someone with radiating lower leg pain. So it's really important that we do a good exam and kind of distinguish the two so that we can get results sooner. Radiating lower leg pain often is a nerve entrapment, and nerves like three things. They like blood flow, they like movement, and they like space. And often in PT, the first thing that we want to tackle is the space component. With radiating lower leg pain, in the absence of something really worrying where I need them to go see a doctor really quickly, what I want to look for is any entrapment sites in the spine or anything down the leg, and there's a few, to see if that's causing the irritation, and then we can do some hands-on work to free that up. These two are really interesting because they're very subtle, but testing should distinguish the two of them. In the clinic, if I'm trying to look for someone that has related lower leg pain, I have a set of tests, and then I'm also going to confirm that we're not getting radiating lower leg pain by running the opposite test too. At the end of the day, a really good treatment starts with really good evaluation. So although I know oftentimes people get really excited to just jump straight into it because they want to feel better, we got to make sure we get all the information first so that we can really set up the right treatment. Another thing to note, related lower leg pain is often associated with this disc presentation that I mentioned, and I think one of the reasons also that we're trying to be judicious in when MRIs are used is because it was an old school thought that if you had a disc herniation, bulge, that it's with you for life. However, there's some research that's showing that's not the case, and actually they can spontaneously regress on themselves. As a matter of fact, even the more intense ones seem to show more instances of regression. So that's great news because a lot of people walk around with this diagnosis of a disc herniation in their head thinking that they have a bad back. That may not be the case. As a matter of fact, your MRI from 5 years ago may look better today. Most of that regression happens in the first year. Sometimes it can take up to 40 months. So if you got an MRI and it had a disc herniation, and then you got another one 6 months later and it still happened, it doesn't mean you're doomed. Again, we have to look at it more holistically with a good physical therapy examination to see maybe what are some contributing factors. Is it a mobility issue, or are you weak? Do you need some spinal stabilization? Moving forward. Now, we've covered the first two, low back pain with radiating leg pain, low back pain with related lower extremity pain. Now let's get into low back pain with mobility deficits. This mobility deficits usually means you're having a hard time moving. It's not a weakness, it's just like a range of motion block. Believe it or not, this is oftentimes when a manipulation can be good. However, this is really when it's in the acute phase and when we don't have symptoms going down the leg. Now, although my bias is that manipulations can often get overused, they can be quite effective, especially in the acute phase. However, we have this clinical prediction rule, which basically is a set of tests that tells us whether a manipulation is likely to yield good results. And one of the things that it says is that the symptoms have been pretty frequent and that we're not getting any symptoms going down the leg, because otherwise we're probably dealing with one of those first two categories. With mobility deficits, we're thinking it's either a muscle that's kind of spasming and locked up, or it's even a joint that's just a little restricted. This is where manips can help. And if there's some fear of doing a manipulation, a mobilization, which is just a lower grade version of that, can also work really well too. A lot of times manipulations feel really good because your body just circulates some new endorphins, but in the case of it, when it fits this clinical prediction rule, the results can be shown up to 6 months. The thing is, anytime we do a manipulation, it shouldn't just be a standalone treatment. It's a way of just helping the body unlock. But after that, we need to go to some postural correction, some strengthening exercises. Whatever we find in the exam is beneficial to the patient. Now, another really interesting thing about this group is what we call active rest, which I think is a tricky one because oftentimes when people have a fresh injury, especially of their back, it's very tender because it's really hard to not have your back involved. So you're getting out of bed, you're turning in bed, and everything kind of jolts. So you just want to totally freeze and stop and not do anything but get out of bed. However, what the research shows that you want to take it easy, but don't be afraid to do things. Like in a lot of cases with the body, total rest often makes things worse and not better because we're getting stiff, our muscles are turning off, and that can happen really fast. It doesn't need to be months of rest. It can even just be 2 days sometimes. So we want to make sure we're taking it easy, but that we're still doing things. Now, the last one is low back pain with muscle power and coordination deficits. This basically means we're not seeing any symptoms go down the leg. It's not a mobility restriction. Oftentimes it's a weakness or they need some stabilization exercise. There is another clinical prediction rule that says whether people are really good for stabilization exercises. Now, this is a really tricky one because I think oftentimes people that fall into this group may not feel like they need those stabilization exercises, but once they do it, they start to feel better. And what stabilization exercises can look like is like some abdominal strengthening, some glute strengthening. It usually depends on what we find in the exam. Now, I know I really kind of just touched the surface level of all of these groups, and that's because it's really hard to go into each one of those in just one video. I'll probably make some more videos going further, diving into each group and what the literature says. However, if you found this video helpful, please subscribe for more videos on performance, wellness, and injury prevention. Follow us on Unity PT LA or go to our website at unityphysicaltherapy.com for more information. Thank you guys and have a great day.